my work was sort of always like sort of like 2 feet in feminist psychology and then a foot in health psychology, and or an arm. Yeah, exactly. It was sort of a game of Twister, and so I think feeling like maybe it was time to get more, traditional training in health psychology and figure out how that merged. Eating disorders is always sort of kind of health psychology, kind of not. Pregnancy as well, so really sort of women's health issues. I also had done work in arthritis and pain management. So I had and was doing work in HIV during my internship, and so I had applied to postdocs in HIV and then cancer, and ended up at Sloan Kettering doing work in psycho-oncology, and through that had a mentor who was focused on issues of hereditary cancer risk, and it was a pretty good match. I also was working with a plastic surgeon I never imagined that I would be, as in my feminist body image researcher. But who was very interested in in what I had to bring. So thinking about decision making, about preventative surgeries, for example, for women who had a history of cancer in their family, and some of the other kinds of genetic issues around living with risk and other kinds of things. So I was in the postdoc not all that long before I started the position at the new school, but sort of just enough to sort of become really fascinated and immersed in these issues, but also to begin to think, how can I do this in a feminist way? Because at the end of the day, doing without asking those critical questions, what assumptions are we making here about women's identity that are not being spoken, about coping that aren't being, that are gendered but nobody's saying. It really permeates cancer research, I think, and somehow I think it becomes harder to say in cancer because cancer is, still a bit taboo to talk about, and something like breast cancer is assumed to, and it is, threatening obviously to identity, but there's something so taken for granted, I think, about the idea that that it would be threatening to one's female identity, that it and there's, I'm certainly not the first person to write about those issues, whether it's Eve Kosofsky Sedgwick, Audre Lorde. I mean, what assumptions are made about gender and breast cancer and reproductive cancer. So then through that, already very interested in reproductive issues through the work with Nancy, but in a different way. There was a genetic counselor who was visiting from Israel who was interested in pre-implantation genetic diagnosis. We began in BRCA, so we began talking, and part of my postdoc grant, one of the goals was really for you to write an NIH grant, so thinking about what would be, through various discussions, combinations, I was a consultant on developing a qualitative study around these issues, and decided I would, had support from everybody to submit that as a grant, just as I was leaving and going to the new school. So some of the work that I began doing there was around decision making about breast reconstruction, but focusing on ethnic minority women who were less likely to get breast reconstruction, and understanding, was that about access to care? Was that about some of the other body image issues, that I've been reading about and writing about, or something more complicated? What was going on there? So that was one, program of research that I began there, and have continued to do and work on. And then this other piece around reproductive technologies and cancer. And so after some just back and forth, I would say, discussion about whether this project gets submitted to Cancer Prevention and Control, which to me somehow, in ways that I can't, that probably would take too long to go into, that felt like the non-critical way to think about this, versus submitting it to ELSI, which was the Ethical, Social, Legal Implications Division of the Human Genome Project. That was sort of what I brought in, that, I think what my community at the Cancer Center knew was cancer prevention and control. So why not submit this as a grant to that division? And I said, I really want to bring in some feminist mentoring. I want to bring in this case, Raina Rapp, who does work around feminism and amniocentesis and reproductive issues as a consultant on this project. And I want to speak to, I want to be able to ask certain critical questions about this issue without just taking for granted that either this is something that should be done or shouldn't be done, but that gives me space to, and a community of reviewers that gets where I'm going with this. And so that sort of threw me into the world of feminism and genetic testing and reproductive technologies. And I was so lucky in that a reproductive endocrinologist who consulted on that study just to make sure that our educational materials that we developed, so we talked to BRCA carriers about their views about essentially screening embryos for the BRCA gene. And so she provided some consultation around some educational materials we gave to people so that they could talk about something that was not completely new to them. Most had, because they were very much dealing with those issues, had knowledge of it. But we wanted to make sure. And who it turns out to be this, wonderful reproductive and feminist reproductive endocrinologist who became very interested in those issues and then sort of invited me to get involved in some of her work and the work she was doing with the feminist bioethicist around egg donation or egg selling, depending on which, depending on where you are, because different countries have different policies, different states have different policies, and issues of anonymity and identity. So, so I'm still in both worlds, but somehow they're intersecting to me and thinking about issues of, I think, reproductive technologies as, I just contributed a chapter to Joan's book on reproductive justice and thinking about they're associated with such elitism, but actually, realizing through, in some ways you learn so much when you write chapters that, the people who are most affected by infertility actually are poor women, who may not have access to these technologies, and sort of thinking about, the social aspects of these technologies as well as the clinical aspects, which of course those are quite big as well, and sort of what is enabled by the technologies and also what is inhibited by these technologies. So it's been, a great space. I think it's a very rich territory for that. Psychologists are in, again, primarily in a pretty conventional way. So how to, I think it's important, obviously, to think about connections between stress and infertility, but again, I think it's more within anthropology, sociology. We have, people asking those critical questions about, when, I think similar questions that we asked about, anorexia, sort of why the quote-unquote epidemic, is there a real epidemic, of infertility, issues of medicalization, issues of access to care, all of those things, and as these technologies really sort of take off and are quite contentious because they intersect with, the ways in which they overlap with stem cells and the creations of embryos and the way they therefore have implications for sort of reproductive choice as well. So it's, I feel like,
amazing.
That I'm in the right places somehow, and again, you find the right people that sort of able to ask, I think, in some ways the same foundational questions about resistance, still within that work, but in new areas and new venues. So as I grow, hopefully the work grows.